Hey everyone, Dr. Shah here, and in this video, we'll be going over complete dentures and the high yield points that you should remember for the board exam. Let's get started. Okay, first things first guys, when fabricating complete dentures, I want you all to remember that patient expectation is the most important consideration. Now, of course, there are other important factors such as aesthetics and function, but managing the expectations of patients is crucial. And you may ask, why? Well, it's because a lot of these patients have only ever experienced natural dentition, which on average can produce 250 pounds of force. Dentures, on the other hand, only produce about 50 pounds of masticatory force, which is a 5-fold difference. That's pretty substantial, guys, and it makes sense. Denture teeth are significantly weaker than natural teeth, and we have to do a good job informing our patients of their limitations. Okay, so now we're ready to make a denture. Among several factors to consider, determining vertical dimension of occlusion, or VDO, is one of the most important. But if you remember, VDO is a tooth-guided position, and for our edentulous patients, that's exactly what we don't have, teeth. So what do? Well, the first step in determining VDO would actually be to first determine the vertical dimension of rest, aka the VDR, which is the vertical distance between the upper and lower jaws when the mandible is in the physiologic rest position. In this position, the distance between the mandibular and maxillary teeth is termed the freeway space, aka the interocclusal distance, and it measures about 3 millimeters. Now, once you have a VDR value, calculating the VDO is actually quite simple. All we have to do is subtract 3 millimeters from our VDR value, and this gives us an approximation of where their VDO would likely be if they had tooth stops, either natural or with a denture. Another important factor that must be determined when making complete dentures is the position we are restoring to. Now, you guys all know about centric relation. It's the most reproducible and stable mandibular position, and therefore it should always be used as the reference point for complete denture, even if only one arch is edentulated. But especially for fully edentulous patients. Because if you think about it, edentulous patients have no teeth to provide a reference point. So centric relation is used as this reference point because it's a reproducible and stable position. Now let's move on to border molding, which is one of the most critical parts of complete denture fabrication, because if done incorrectly, as shown in these images, you're really going to have an unhappy patient. So please make sure your border molding does not look like this in the clinic. Alright, let's see what a good example of border molding looks like. Look at this, much better. Notice how the borders aren't paper thin, but instead are replicating what the vestibule looks like? That's what we want to see, because at the end of the day, guys, border molding is performed to record the details of the vestibules. So different movements capture different parts of the maxillary and mandibular arches. For instance, the labial flange can be recorded by having the patient pucker their lips, and the retromolar pad and masseteric notch can be recorded by having the patient close against pressure. You want to get this step right because incorrect border molding can really cause havoc for a denture. For example, too little border molding will lead to overextension of the denture flange, which is the most common cause of inciting the gag reflex in patients with dentures. Additionally, during the border molding process, a posterior palatal seal should be created in order to compensate for the polymerization and cooling shrinkage of the acrylic resin material. Shrinkage typically causes the denture base to lift up from the posterior palate, but the posterior palatal seal area, which is placed on non-keratinized displaceable tissue, would overcome this by providing a vacuum-tight seal to hold the maxillary denture in place. Alright guys, since it's such an important topic, I want to show you guys the effects of poor border molding in a more easy to understand way. Underextended flanges, such as the buccal flange shown here, occur when border molding is too aggressive or if the custom tray was underextended in the first place. The main thing to note here is that underextended flanges can lead to food impaction and a sunken facial profile. Similarly, overextended flanges occur with insufficient border molding movements or an overextended custom tray. These overextended flanges can cause rocking of the denture base, dislodgement of the denture, a feeling of fullness of the lips and cheeks, and obviously sore spots in the area of overextension. The one thing that actually makes overextended flanges an easier problem to deal with compared to underextended flanges is that you can actually fix an overextended flange by just adjusting the flange back to where it should be, whereas fixing an underextended flange is kind of difficult since you can't just add acrylic to an already processed denture. Another issue with overextended flanges, more specifically an overextended mandibular lingual flange, is that the denture can easily be displaced when the tongue is protruded. This is because of the mylohyoid muscle, which supports the floor of the mouth and can push against the poorly fitting mandibular denture when the tongue is protruded, causing it to shift or move out of place. This is exactly why during boredom molding, one of the movements we instruct the patient to do is to lick the sides of their lip or the corners of their mouth, since this movement brings out the tongue and molds the lingual flange to an appropriate length. Okay, we're going to talk about occlusal schemes a bit more in depth later on, but I just wanted to introduce the topic and mention that the most ideal occlusal scheme for removable prostheses is bilateral balanced occlusion. Now, this concept is something a lot of students struggle with. So what is bilateral balance? Well, in simple terms, bilateral balance occlusion describes a scenario where the anterior and posterior teeth contact through all movements of the mandible, hence the term balance. So let's take this patient as an example. Here we see the dentures in a biting position. Now let's imagine this patient protrudes their mandible. And since these set of dentures were fabricated with a bilateral balanced occlusal scheme, we see that even during protrusion, we have front teeth contacting as well as posterior teeth. This essentially acts to distribute occlusal forces evenly across the edentulous arches, ensuring that we don't get tipping or dislodging of the denture. So in reality, bilateral balanced occlusion gives a great deal of stability to our dentures, which is why it's the most ideal occlusal scheme for removable prostheses. The only caveat here is that bilateral balanced occlusion is best achieved with posterior teeth that actually have cusps, or in other words, cuspal angulations. Something like a 20-degree occlusal angulation is good because that's what's going to cause the dentures to contact during movements. And that's what we want for a bilateral balanced occlusion. But this isn't ideal for all patients. For patients with advanced ridge resorption, these type of teeth can actually be destabilizing. What they really need is teeth that minimizes lateral forces, and that's essentially flat teeth, or in other words, 0-degree teeth, because these will be non-interfering. Another important point when it comes to teeth setting concerns the actual placement of anterior teeth. More specifically, if they're positioned incorrectly, the patient can develop sore spots in the residual ridge as shown here. Once the teeth have been set, in order to determine if adjustments to the positioning of the denture teeth need to be made, the patient can be asked to pronounce different sounds. Fricative sounds such as the F, V, and PH sounds help determine the position of the incisal edges of the maxillary teeth. If the maxillary anterior teeth are set too low, F sound pronunciations will begin to sound like V sounds. You can try this yourself by saying a word that has both sounds in it, for example the word 5. You'll notice that the positioning of the maxillary central incisors for the F sound is very similar to the V sound. Alright guys, once the teeth are set and the try-in is complete, the wax denture is ready to be processed into an acrylic denture, and there's many different techniques to do so. There's injection molding, compression molding, different types of acrylics, etc. But to be honest guys, you don't really need to know a lot of that. Instead, I'm just going to give you a couple points that you should just memorize since they tend to sometimes show up on the exam. First, know that the acrylic we use has a monomer component, and if it's present in excess, it can really cause some issues for the denture, such as extra shrinkage. In light of that, any excess monomer should be disposed of according to the material safety data sheet. The second point to remember is that the injection molding technique, along with heat-cured acrylic resin, will give us a denture that's most resistant to yeast infections, or in other words, a denture that will have the least C. albicans adherence. Alright, so the denture is fabricated and delivered, and our patient, who let's say had full mouth extractions completed a month ago, comes in complaining that the denture you made is rocking and not fitting well. Which, to be honest, is normal after full mouth extractions, since there's going to be a lot of remodeling happening of the residual ridge and tissues. So just remember that ill-fitting dentures will typically rock either due to a lack of retention or a poor fitting base, and oftentimes both. And if the intaglio fit is really bad, then we can reline the denture using some good old chairside cold acrylic resin. This can be done for patients with interim and immediate dentures during their healing phase, but it can also be done for long-term denture wearers right before we begin the process of creating new ones, because relining the denture will actually allow the tissues to heal and be ready for our boredom molding and final impression appointments. So relining is a very versatile process. Alright guys, that's it. Now let's take everything we've learned and tackle some practice problems together. And the first question is, what is the masticatory efficiency of denture patients compared to fully dentate patients? Pause the video if you need some time to get your answer, but the answer is B, 20%. Remember guys, there's a 5-fold difference in masticatory efficiency in patients who have complete dentures compared to patients who have natural dentition. Alright, moving on to question 2. Which movement during border molding creates the labial flange? Saying ah, protruding the tongue, puckering the lips, or closing against pressure? And the answer is C, puckering the lips. Saying ah isn't actually a border molding movement, it just determines the position of the vibrating line. Protruding the tongue helps border mold the lingual flange, and closing against pressure helps to border mold the distal aspect or the distal flange of the mandibular denture. Therefore, puckering the lips is really the best answer here. And you can always try these during the test as well to feel which areas of the mouth are moving. All right, moving on to question number 3. When a patient is asked to say San Francisco, what aspect of the denture is being evaluated? Interocclusal distance, centric relation, stability and retention, or bilateral balanced occlusion? And the answer is A, interocclusal distance. Now, I actually didn't directly discuss the concept of closest speaking space in this video, but that's what this question is getting at. We typically have patients say words with sibilant sounds, such as Mississippi or San Francisco, to look for about 1 millimeter of interocclusal distance around the canine region. This is kind of a check to make sure that we have our dentures at the right VDO. Alright guys, here's a quick summary of the high yield points we just covered. Thanks for watching, and I'll see you in the next video.